In this episode of the BFR Better for Results podcast, we sit down with Tim Werner, associate professor at Salisbury University in Maryland, whose expertise is in arterial stiffness. In the continual pursuit of optimal, Tim's expertise in arterial stiffness helps explain the huge therapeutic impact that both resistance and aerobic exercise has on systemic health. In this episode, we dive into the physiology of arterial stiffness, why we should care about arterial stiffness, how disease impacts arterial stiffness, and its potential impact on exercise prescription. We also spend some time talking about our work together in investigating the impact of autoregulation in arterial stiffness in upper and lower body exercise. Hope you enjoy the episode. Welcome to the podcast, Tim.
Hi, Nick, and hi, everyone. Thanks for having me. I'm definitely looking forward to this, diving a little bit deeper into the influence of arterial stiffness on our health and how exercise can definitely influence it. So,
and we all know how important exercise is. But before we get started, just want to give the audience a little sneak peek at who you are and why you ended up at Salisbury, and kind of how you got interested in arterial stiffness in the first place, because that's a very interesting topic, given that when we strength train, a lot of times people are focused on more of the peripheral or brachial measures of systolic and diastolic blood pressure, but people forget that the blood's got to come from somewhere, right? It's got to come from the pumping heart, and measuring that those values could have some significance in our exercise prescriptions. So I'll let you take it away.
Well, like a lot of you, I started off wanting to work with healthy athletic populations. And so my undergraduate and my master's degree was mostly focused on just improving rowing performance. And that's where a lot of our research was headed. Then I got involved in Virginia Tech, and Virginia Tech was very clinically oriented. The researcher there, Dr. Kevin Davey, who's still there, took me in and introduced me to arterial stiffness and why I needed to know it and why we need to study it. And so under his advisement and mentorship, I became very attuned and very accustomed to the exercise regimen as it applies to arterial stiffness. Now, what that means is that we spent a lot of time in the lab capturing indices of arterial stiffness, which we could get in later. But more importantly, we were interested on how you can slow this thing down or what speeds it up. And so Dr. Kevin Davies' lab was very interested in things that might accelerate arterial stiffness. And so what he did is one of his studies, he actually had subjects gain weight to prove that weight gain is associated with arterial stiffness. Now, when I came along, a lot of our studies were focusing on drugs, beta blockers, ACE inhibitors, and things like that, and whether or not a combination of those drugs with exercise or exercise alone was more beneficial. And what we're finding is, typically the synergistic approach is probably better, but exercise can still be very, very beneficial at the end of the day. So that got me really interested. And so my dissertation was on the effect of exercise and beta blockers on arterial stiffness. And then being in that world for a while and the competitiveness, the cutthroat environment kind of steered me towards a D2, D3 school setting. I knew that I did not want to live the life of a Research 1 professor. A lot of those folks, they're spending many hours on weekends collecting data. And I had this a passion for teaching as well. And so I wanted to be at an institution where I can primarily focus on teaching, but I also wanted a play around in the lab a lot. And so Salisbury University was a good fit for me. So it allows me to do both. And so in my little arena inside Salisbury University, I've dabbled in many studies involved with looking at arterial stiffness with resistance training, using creatine, using fish oil. We did a study on the effect of CrossFit training in arterial stiffness, basically just trying to characterize how the different modalities, intensities can affect arterial stiffness, and if they even have a negative impact. That is something that we're very interested in discovering. For the most part, no. Exercise seems to be very protective, and in some cases, rescuing folks from a fate of arterial stiffness. So, it is indeed medicine. As I teach my students, it's literally just get up, do some exercise, and you can improve your cardiovascular system without the need of medication. It's really, really potent stuff. So a lot of the stuff.
Let's talk first and foremost about what actually arterial
Sorry, you had a lot of questions
is.
there.
And so we understand that we can impact it through exercise, which is great. I think exercise, as most would agree, is one of the best ways to improve overall health and wellness. But that still begs the question of what exactly is arterial stiffness? We just lost your mic. So you just
can you hear me now?
Yeah, now we're good.
Okay. So what is arterial stiffness? Arterial stiffness is a process of the protein network, the extracellular matrix of the blood vessels changing over time. A very healthy elastic arterial system will have a high composition of elastin protein inside of it that allows the blood vessels to stretch and recoil as blood is being pushed through it. Arterial stiffness is a changing of that composition into something that's more stiff in general. And generally, the current rationale is that the elastin filaments or proteins become fragmented or reabsorbed, and they're replaced with collagen fibers. And those collagen fibers bring about a characteristic inside the blood vessel where it is unable to expand and recoil. So it's stiff. And the issue with that is now the heart is pushing through a tube that is resisting the blood flow. Under normal, healthy circumstances, when the heart contracts, the elastic arteries of your central vasculature, they dilate, and that helps to dissipate energy that's coming from the left ventricle. And that dissipation of energy helps to lower systolic blood pressure as it travels throughout the body and eventually hitting those small, delicate capillaries that are one layer thick. We need that. Now, the other important thing about elastic arteries is that when they're expanding and the heart is back in diastole, they're going to be able to recoil. And as they recoil, that's going to help push blood continuously during diastole. So it's actually functioning like a artificial heart, if you will. Through that recoil helps to continue the perfusion of blood flow throughout the body. So generally speaking, when you see healthy arterial systems, we generally see a lower systolic blood pressure and a somewhat normal, maybe elevated diastolic blood pressure. And a lot of people get this wrong. They assume that healthy arterial systems, you need low systolic and diastolic. Well, to answer that question and to wrap your hand around this a little bit better, you have to think about what causes systolic blood pressure. Right? Left ventricle, right? So when we are lowering systolic blood pressure inside the artery is going to be able to expand and it dissipates. It acts like a buffer. And so if we see a reduction in systolic blood pressure, that tells me that the arteries are doing its buffering thing. It's able to lower the blood pressure. But in terms of diastolic blood pressure, a lot of people are not not very attuned to what's causing diastolic blood pressure. And so it's not the left ventricle. Part of that pressure during diastole is coming from the recoil of that artery. So I would expect to see an increase in diastolic blood pressure in healthy arterial systems. And this created a paradigm shift in the way we're arguing about treating folks with high blood pressure, because normally you get treated if you had very, very high diastolic blood pressure. And this research is looking at the fact that, wait a minute, it could be a good thing to have high diastolic blood pressure in the context of a high systolic blood pressure. So stiffer arteries generally can be measured in certain ways. We can take videos of the artery. Mainly the artery itself is going to be captured on an ultrasound B mode, where I can see the expansion and the recoil of the artery. And for obvious reasons, if that artery is not expanding as much or recoiling as much as it could before, we can deduce that it's becoming stiffer. Another way to capture it, the gold standard way, is to measure something called pulse wave velocity. Pulse wave velocity is a concept where we measure the speed of the pulse as it travels through the artery. So when you feel your pulse on your wrist here, right, that actually starts in the heart, and it travels throughout the arterial system, up the head, down to the legs, and it reflects. There are sites of impedance all along the arterial tree that causes the wave to reflect back to the heart. And what I do is I simply just measure the speed of that pulse as it travels to and from the heart. The faster the pulse is traveling, the stiffer the arteries are. And the analogy that I like to give to my students is, imagine if I had two different material tied to a doorknob. So in my one hand, I had a rope, and the other one, I had a wire, and I flung them both at the same time. And you can see the wave traveling. Which one's going to travel faster? It's going to be the wire, because it's made of stiffer composite, stiffer material. And the same principle can be applied to the arterial system. When the elastin fibers are being replaced with collagen, that pulse wave is going to travel faster inside of it. And so I simply just measure how fast that pulse is traveling throughout the body.
Do we know what the amount of, like, what's a normal value of?
That's a great question. Great
pulse
question.
Wave
So
velocity?
Right now, we do not have a cutoff range like we do with blood pressure. Everyone knows that healthy blood pressure is anything less than 120 over 80, right? Anything above 140 over 90 is stage 2 hypertension. We don't have that yet for the arterial stiffness. Now, looking in the
Why
literature,
do you think that is?
It's a newer concept. If you look at the literature and you ask how long does it take for the stuff that we learn in the lab to be brought into the medical profession, on average, it's around 17, 20 years. So
17 years.
And this is taking a lot longer. So
why, like, that to me is such an interesting observation, because we focus so much on the management of brachial blood pressure. And I think what we established is, in the conversation thus far, is an increase in pulse wave velocity. It just means that there's a stiffer artery. Now, my next question is, since we don't have any normative values for pulse wave velocity, it's almost difficult in measuring it then, because we don't have any standard by which to compare our data. So the question then becomes, okay, we have stiffer arteries, right? What are stiffer arteries generally associated with in terms of risks? And then also, does an acute observation of an increase in arterial stiffness, however you're measuring it, because there's a number of ways, let's just stick with pulse wave velocity, is that necessarily a bad thing given the potential for our body to adapt? So I know there's a lot of questions here, especially since, you know, a lot of people are like pulse wave velocity, arterial stiffness. I've never heard of any of these things.
So there is a consensus gathering that if you have a pulse wave velocity greater than 10 meters per second, so that has been associated with higher risk for cardiovascular disease. If you look at some of Gary Mitchell's data from the Framingham study, it suggested that anyone with a pulse wave velocity over 12 meters per second had the highest risk for a future cardiovascular event versus any of the other quartiles. So what does arterial stiffness end up doing, right? What does it do to the heart that's so bad that can cause these issues? Well, it does a couple things. So if your arteries are stiffer, right, the heart's going to have to contract with more vigor, with more aggression, right? And so it's going to have to squeeze harder. When the resistance against that squeeze builds up, the heart has to adapt. And how does the heart adapt? Just like your skeletal muscles do when you add heavy weight to it. It's going to hypertrophy, and that's going to evolve into left ventricular hypertrophy. Some of the issues with left ventricular hypertrophy is the ventricle gets smaller and smaller. So ejection fractions can be compromised when the ventricles are getting smaller and smaller. Another issue,
and that's not, but just for clarity, right? The left ventricular hypertrophy in this sense is more of a concentric left ventricular hypertrophy, correct?
Mm-hmm.
So the
correct.
eccentric.
Yeah, eccentric is increasing ventricular size, correct.
And so yeah. that's the adaptation that happens with a healthy heart. But an adaptation that happens with an unhealthy heart, or a heart that's working just too hard, is we should see an increase in concentric ventricular
remodeling. Correct. Absolutely. So the other part is it's actually referred to the pulse wave. So when you have stiffer arteries, the heart is not going to be able to perfuse its own myocardium. And it has to do with the pulse wave. So bear with me. I'm going to try to simplify this. So when that pulse wave is sent out into the periphery, right, it's going to bounce off sites of impedance, and it's going to come back to the heart, usually in a healthy system during diastole. So as that pulse wave is coming back to the heart, what it's going to do, it's going to help to push the blood that's in the aorta through the coronary vasculature to feed the myocardium. 95% of the blood flow to the myocardium happens during diastole. So in a stiffer arterial system, what we have is a very fast traveling pulse wave. And that pulse wave comes back during systole, not diastole. And so you miss out on that opportunity to perfuse the tissue of that heart. And that leads to ischemia and heart failure. So it's those two pathologies that are thought to be the most important in terms of the risk of arterial stiffness. Arterial stiffness is considered one of the best predicting values for a future cardiovascular event. In my world of hold on, sorry, Nick. Crap. In my
your mic came off. Yeah,
sorry,
now we're good.
All right, your editor's going to kill me. So one of the things that I just lost my thought.
So talking about arterial stiffness and different conditions, and you were going on looking at the importance of arterial stiffness. I mean, for me, I think where this kind of goes is, okay, you've established that arterial stiffness is something that we may need to pay attention to, particularly in those that have comorbidities. And so my next question is, like you said, heart disease, heart failure, cardiovascular disease, heart failure, is what other conditions do present with increased arterial stiffness,
Yeah,
and
great question.
how, what does the evidence say regarding managing those types of
Great
individuals?
question. So, what are some of the risk factors for developing arterial stiffness? Absolutely. So, we do know that arterial stiffness is highly correlated with diabetes. The high levels of glucose flowing continuously around the blood have been shown to cause collagen cross-linking and elastin fragmentation. So it speeds up the process of stiffening. So if you're a type 2 diabetic, you're at increased risk of arterial stiffness. We also know that arterial stiffness is heavily associated with inflammation. So if you have a high inflammatory environment, this low-grade systematic inflammation, a lot of pro-inflammatory cytokines, C-reactive proteins. I could go on and on. A lot of these compounds have been shown to accelerate the stiffening process. And the third stressor or factor that can really modulate arterial stiffness is blood pressure per se. Blood vessels adapt. And when there's a lot of pressure on that tissue, it's going to want to strengthen itself to increase its stability, to increase its strength so it doesn't rupture. And one of the things that it undergoes is it's going to change its elastin network. It's going to remove a lot of that elastin, replace it with the collagen fibers. Now, it's going to be much more resilient and it's less likely to rupture. But at the same time, it's going to have some clinical consequences on the heart. Mainly, like I said, left ventricular hypertrophy and ischemia are typically the outcomes of that.
So when we think about, like, I like to think about the body's ability to adapt, and that adaptation process is a stressor in and of itself. When we think about the most common example that I'm interested in is hypertrophy or growing muscle. We see the occurrence of muscle damage that ultimately kind of goes away after we do it. That's an exercise bout a couple of times, and then the muscle ultimately is able to grow bigger through elevations in utilizing that muscle protein synthesis, that stimulus, from now reverting from a muscle damage and repair to a muscle growth perspective.
Yeah.
Tendons become stiffer. Bones tend to increase in bone mineral density. So I guess my interest in arterial stiffness is, if you're saying, that this process of stress, right? Is there a good stressor? Meaning that obviously we have situations where there's comorbidities, where you're having heightened levels of chronic low-grade inflammation that can produce those increases in arterial stiffness. But I'd like to think that the arterioles themselves and the arteries undergo a similar type of stress response. And so I guess my question is more along the lines of, okay, you stress the artery in a healthy way. Is there, knowledge about the timeline of those adaptations? Are they similar to strength training and muscular adaptations? Are they different? And, is there too much of a good thing? Like, if I'm exercising a ton and I'm like, all right, I want to do tons of cardio, is that associated with stiffness and, just too much of a good thing?
Great question. So you look at the three factors that can stimulate arterial stiffness, high glucose, inflammation, and high blood pressure. So we have to do an attack on all three. And so in my mind, the best treatment for that is exercise. So exercise can be a positive stimulus for arterial stiffness in the fact that it can lower blood glucose. We know that from clinical trials that individuals who are diabetic can see clinically relevant reductions in blood glucose. We also know that exercise, aerobic, and resistance training are potent anti-inflammatory treatments. So someone who does consecutive or consistent exercise over a lifetime is going to have a lower inflammatory profile. And so you're not going to see as much.
Why is that? I think why is that? Because I don't think a lot of people appreciate the fact that exercise is actually, in the macroscopic view, anti-inflammatory.
That's where all the magic happens. So I teach clinical exercise physiology at the undergrad and graduate level, and this is literally where exercise has most of its impact. It is anti-inflammatory. Now, how is it anti-inflammatory? Well, it's going to attack the agents that are creating the inflammation. What creates inflammation? We know white blood cells. We know fat cells. Fat cells are very inflammatory. Not the fat cells that are on or underneath your skin, the subcutaneous fats. It's the visceral fat that is very
Why is that?
That's a great question. Why did evolution decide to have so many of these cells in our belly to be inflammatory? But to take a deeper dive there, what we do know is that the fat cells, liver cells, the blood cells, they all evolved from a similar stem line. So, thousands and thousands of generations ago, these cells were pretty much coming from the same stem line, and they all had the same characters or similar characteristics. One of them being able to produce these inflammatory compounds to let other cells know that they're being attacked or hungry or whatever. Hundreds of thousands of generations to today, we still have these cells with the same genetic programs inside them, producing the same types of pro-inflammatory responses. Now, when you add the fact that these folks are having excessive amounts of these fat cells that are able to produce these pro-inflammatory cytokines, that is the critical link between many chronic diseases and inflammation. So when you have a lot of fat cells producing these inflammatory compounds, we know that inflammation can cause arterial stiffness. It's linked to dementia, diabetes. We know it accelerates cancer. It's associated with anemia. So you go on and on. You can look at the mechanistic aspects of inflammation and how it plays its role in all these unique chronic diseases. And it really just stems from having an excessive amount of fat cell. But I don't want to just blame the fat cell. There's lifestyle behaviors that can also contribute to this as well. But the point is that exercise is anti-inflammatory because it can reduce the amount of pro-inflammatory cytokines being produced by these visceral fat cells. We also know that muscle cells, as they become well-trained, they produce much more anti-inflammatory signals, which can help in the situation. So literally, exercise is medicine. I've seen people cured of their diabetes because they exercise. And they can shift their inflammatory environment from one that was pro-inflammatory to one that's anti-inflammatory. And that helps to relieve the insulin inhibition that's going on inside them. So it is indeed a very powerful aspect of exercise, one that a lot of people don't appreciate.
I can't agree with you more. I mean, I don't think we're ever going to develop a pharmacological intervention that's going to target as many genes as staying active. And I think that ties back to just in general my mission of promotion of exercise and helping get people back to the activities that they love as quickly as possible through things like exercise, like BFR, which we'll segue into in a little bit, to help get them moving. And I think in relationship to your expertise and arterial stiffness, what are things, since we've established now that we should care about arterial stiffness, however, the evidence right now doesn't have a firm cutoff values for post-exercise changes, right, acutely, what, given the potential concerns regarding exercise-induced increases in arterial stiffness, what has been observed in long-term strength training and aerobic training programs that may suggest that the arteries, even with the potential for them to become a little bit stiffer in one way, shape, or form, actually undergo adaptation, like muscles and tendons and bones?
So this is definitely an area of controversy. Does resistance training per se induce arterial stiffness? And intuitively, you would think that when you're doing resistance training, you're going to have very high levels of systolic blood pressure and diastolic blood pressure. You know, I've seen systolic blood pressures as high as 350 millimeters of mercury during a squat. You know, that's momentarily.
Have you seen the McDougall? There was a McDougall study in 1985. It was like in a instantaneous peak systolic blood pressure of 480 over 350 or something along those lines, where it's just so absurd.
Yeah.
But it also highlights the fact that our arterial system has the capacity on peak value to be able to actually manage a spike like that.
So I just want to make it clear that was only for a few seconds. I'm not saying undergoing that pressure 24/7 is a safe thing, but suffice to say, the idea is that if you expose yourself to that type of stimulus over time, the arteries are going to remodel. They're going to put more collagen in. And what the research has shown, at least my research, is that resistance training does not modulate the stiffening process. The concern when I was, growing up is that if you had high blood pressure, you shouldn't do resistance training because that will raise blood pressure, right? You'll have higher blood pressure after the exercise, and definitely a few months into it, you'll have higher blood pressure at rest. It was based on anecdotal bad evidence. There is no evidence to support that today. If you look at the ACSM recommendations, in general, it can lower blood pressure a little bit by 3 or 4 points, but the point is it doesn't raise it. And so we're also seeing that with resistance training. It doesn't benefit our stiffening process, but it doesn't hurt it either. So do resistance training if you want without fear and retribution. Essentially, it's a great thing for your body.
And what about aerobic? And what about aerobic? So we have a negligible to slightly reduced pulse wave velocity, arterial stiffness / may or may not correlate with a drop in systolic. So is there a different response to aerobic exercise? And if there is, why is it postulated that happens?
That's a great question. So a couple of things with aerobic training, you don't see the large spikes in blood pressure. Yes, systolic blood pressure goes up, but not to the extent of resistance training. Another idea or mechanism at play here is we know that aerobic training seems to be more potent in terms of producing anti-inflammatory products and reducing pro-inflammatory cytokines and chemokines and things like that. So with that respect, one of the reasons why we see this lower stiffening process in folks that do a lot of aerobic training compared to their sedentary non-trained counterparts is because of this lower inflammatory profile that type of training brings about, and that protects against a lot of the stiffening process going on. It discourages collagen cross-linking. It discourages elastin fragmentation. And these are all good things if you want to maintain an elastic profile.
So what then does this say about acute measures of arterial stiffness? If we're, what is the potential relevancy that we can get from these type of investigations?
So that's another great question. It's important because we have to understand if the exercise regimen is going to be acutely dangerous for someone. So someone has high blood pressure, they have diabetes, they might have had a recent heart attack. You know, you go down the list. We need to establish the fact that will exercise raise arterial stiffness acutely, and will that have an impact? So far, in our research together, we have not seen that, right? The exercise acute response generally shows that arterial stiffness, it doesn't stay elevated very long after exercise. And that is a great thing to know, and knowing that this individual that we just trained can go back home without fear of any reactions or secondary outcomes from the exercise. Now, one can also point out the fact that what's the clinical significance of knowing the acute response if someone only trains once a month or every 2 months or something like that? No, there is no clinical impact. So the more impactful studies, of course, will be the long-term studies that will give us a better idea of the overall impact of training, whether it's aerobic training or resistance training, on the occurrence of arterial stiffness. So it's been a couple of years, but I've completed 2 such studies, resistance training studies. And I did one resistance training study for 12 weeks in untrained males. And then I went back and I did another 11-week resistance training study in females. And I put them on a training program that was recommended by the National Strength Conditioning Association. So it was a full body workout. They were training 3-4 days a week in the gym. And I was measuring arterial stiffness profiles throughout. And we saw no increase in arterial stiffness after a more chronic intervention. Now, people can fault us and say 1 out of a year or 2 years. So there are limitations with that. But the fact remains that it seems, at least for the first few months of training, that you should not have any impact on your arterial stiffness scores. Stay tuned.
Should after 3 months of training, should there be a divergent response?
I would not anticipate, but that's speculation right now. So that does require further investigation. But at this point, there's no evidence for me to believe that.
Okay. So there's going to be a lot of people that are listening that are clinicians working with people that have comorbidities. Is there any way, that easy way or clinically feasible way, that people can get an idea of the person that they're working with's measure of arterial stiffness? I know you're skilled in pulse wave velocity, and that is a dual task type of measurement. But is there anything that's clinically available that can give you some ballpark idea, or is this really left for like the exercise physiology lab?
So the closest non-invasive at-home measurement is pulse pressure. So pulse pressure is a very simple metric. You just take someone's systolic blood pressure and you subtract it from diastolic blood pressure. And what it tells me is the pressure gradient between the difference between systolic and diastolic. And generally speaking, I want to see a pressure gradient around 40 millimeters of mercury, 50 millimeters of mercury. And if that pressure gradient is expanding, if it's getting bigger, that tells me that systolic blood pressure is higher and diastolic blood pressure is dropping. That is indication of stiffer arteries. So if there's a larger pulse pressure, but I always have to say this with a caveat, there are some strong reservations against that method. It's heart rate dependent and some other things. So please do your due diligence, and if possible, get your arterial stiffness score measured either with an ultrasound or some type of arterial tonometer.
Yeah. So how is that process kind of done.
Yeah.
If
So,
somebody is like, hey, I might be a little apprehensive about putting this person through a moderate to high load strength training program, um, where could, how does that process look?
so this is one thing that we've been fighting for a while. In an ideal setting, we would have everyone's arterial stiffness measured at the physician's visit. But it does take time. For one, the individual has to be laying down for at least 10 minutes. And then what I do is I place tonometers on the carotid artery, on the radial artery, and then also their femoral artery. And
Tonometers are
tonometers are pressure receptors. Can they can measure the presence of a pulse wave, the timing of the pulse wave. So the only other thing you need is an ECG. So the ECG tells me when the pulse wave starts. You look at the R wave off of the ECG. That starts the time watch, if you will. And once the pulse wave hits the arterial site, we stop the timer. We measure how much time it took to go from here to here, or here to the radial, or here to the femoral. And then simply all you have to do is with the measuring tape, you just have to measure the distance between these sites. And you can get meters per second pretty quickly. So that's probably the easiest. And by the way, gold standard way of doing it is measuring something called carotid femoral pulse wave velocity. Is simply just putting those tonometers on the arterial sites, getting that time measurement, and then just measuring the distance between them. Now, another way to do it is looking at the diameter of the carotid, or if you have better, more sophisticated equipment, looking at the diameter of the aorta itself, but seeing how far it can expand in recoil, and just measuring those changes over time. Is it expanding more, recoiling more, or is it less? So just a snapshot view of these scores of those images won't tell me much. I would have to see that over time, because again, we are limited in terms of scale. We can't tell you exactly when you're at very, very high risk of a future cardiovascular event. We have some associations, like if your pulse wave velocity is over 10 meters per second, that we know that you're higher risk, but how much higher, that still has to be worked out.
What about acute increases? Is there any cutoffs that you're aware of for
Not that I'm aware
that?
of, no. So if we're seeing acute bouts, generally, an acute rise in arterial stiffness does not lead to, chronic heart remodeling per se. So this is a process that takes many, many years to develop. So it's not going to happen overnight. So if it's a consistently acute response every time after exercise, yeah, then I would be concerned. But one acute elevation in arterial stiffness is nothing that I would be concerned with at this point.
All right. Well, is there any other pieces of info related to arterial stiffness that people don't really appreciate or aware of that they should be aware of? Or do we cover kind of the nuts and bolts of the significance of arterial
Mm-hmm.
stiffness? I guess for me, I'm still, when I first, I think my third publication was was a systematic review
Mm-hmm.
that was on the arterial stiffness effects of blood flow restricted exercise.
Mm-hmm.
And that was the first time, believe it or not, that I was ever actually introduced in any capacity to measures of arterial stiffness. And so I guess for me, the question becomes, why hasn't arterial stiffness, not saying that it hasn't caught on, but why hasn't it caught on as something that people are considering, given that this is really measuring the strain on the heart and the stress on the aortic arch?
That's the $64,000 question. What's in the
Just
way?
64,000? Just 64?
Yeah,
Okay.
or maybe in today's money was that $64 million question. So possibly it could be politics. One of the issues with arterial stiffness is that's going to be an extra stress on doctors during doctor visitations. That's an extra 15, 20 minutes that someone's got to spend in the physician's office to get these measurements. We don't have a very quick measurement like we do with blood pressure. um, I think
I guess for me,
yeah.
thinking about it too, it's if somebody, for example, if I'm working with a client or a patient that has blood pressure of 150 over, 80 or 150 over 90, do I assume that they have higher degrees of arterial stiffness than somebody who's at 120 over 80?
If it's a consistent elevation, yeah, I would err on caution there. So I would definitely. Can you say that question again so I don't screw up the answer?
Well, no, just saying like if you have somebody that's like 150
Yeah,
over
you can edit
over
this.
80
Yeah.
versus one
So yeah,
that's
I would definitely think that the individual with the higher blood pressure has the higher risk, not guaranteed risk, but a higher risk of the arterial stiffness process happening.
and
Now, the
then does
person with
that
120 over
impact
80,
yeah, I
what?
mean, but does that impact your exercise selection with somebody? So if you're saying, hey, um, like I'll give you an example. Like when
Yeah.
I'm working with somebody and I know that they're hypertensive and I may or may not be applying blood flow restricted exercise or blood flow restriction to them, there are certain things that I go through in my head of, oh, well, maybe if I don't want to spike their blood pressure, I'm going to reduce the total amount of muscle mass that's going to be involved. Maybe I'm going to program BFR a little bit differently than I would someone who's normal tensive. Is there something that we should be aware of? So say we have somebody that we know has stiffer arteries.
Yeah.
Does that impact our programming in any significant capacity?
Currently,
Or is that
no,
just
it does
more
not.
like in the back of our mind, this is their underlying physiology and we should just be aware of that?
Currently, there is no recommendation. So I default to the ACSM recommendations for hypertension. So, for instance, if someone has a blood pressure over 200, systolic blood pressure over 200, they are generally ill-advised to begin an aerobic training program. If they're about to do a resistance training program and their systolic blood pressure is over 180 millimeters of mercury, then they're ill-advised to do a resistance training program on that day. Generally, what we say in that situation, you probably misdosed yourself or underdosed yourself. Go home, make sure you take your medicines, come back, and let's try it another day. But right now, we do not, as you pointed out, we can't measure someone's arterial stiffness and say, okay, it's good for you today, go ahead and work out, or it's not good, unfortunately. I would think that would be a better index of risk profile versus the blood pressure assessment. But again, we're still lacking in that research.
And how much do these pieces of equipment go for? Right. And how is
Yeah.
the training process to actually do that? So if you're somebody who, say I wanted to add this as part of my assessment, what are kind of the steps that you would have to go to integrate this into your practice?
Depending on the model, I mean, there's some that can go for $10,000. There's others upwards of $50,000, depending on your wants and needs. Yeah. So the most common one that I see is the Sigma Core tonometer. It runs about 20 grand. But again, there are a lot of choices out there depending on your wants and needs, whether you want to just collect central pulse wave velocity, if you want to collect peripheral and central pulse wave velocity, or if you want to get really into the pressure wave itself, looking at augmentation index and some other variables. It just depends on what you're looking for, what you want to analyze.
All right. All right. Yeah. I mean, I'm always looking for ways to try to integrate back into practice because, we can all be very interested in the physiology, but if we can try to apply this knowledge into our day to day in some capacity, it's always a bonus. So yeah, so pivoting, I
I was
wanted
just
to,
going to
unless
say
you had
really
any
quick, Nick.
other, yeah.
So the actual technique itself is not very difficult. I mean, someone can learn this in probably just a few days of being able to palpate for the pulse, placing correct pressure. I would say be the hardest part. So you don't push too hard, but to erase the pulse, but you also don't want to press too lightly, and that can change the pressure reading. So it does, in that respect, it does take a little experience, but this is not rocket science. I'm literally just putting devices to capture a pulse wave as it travels through the artery, and then I measure the distance that it travels. So it's not terribly complicated.
All right. Well, that's always good to know. I'm thinking about doing some ultrasound, diagnostic ultrasound, and integrating that into my practice, because I feel that it could help contextualize in certain circumstances how I'm integrating, my interventions or explaining to clients or patients or something. So any opportunity where there's a low barrier to entry, because ultrasound is a very high barrier in terms of contact hours and everything. Is there anything else on arterial stiffness in the physiology
Yeah,
or anything cool that we haven't
yeah.
really
I think you'll
discussed
like this.
before?
So when you take your blood pressure in the periphery and your brachial artery, that's not your true blood pressure. That's the pressure in your arm. We are interested in the pressure that is outside the aorta. We want to know what's going on just outside the heart. And so the pressure that you have here in your brachial artery is rarely does it equal the pressure in the aorta. Most of the time it's going to be lower. And that's what some of the things that we're finding is that your central blood pressure, systolic and diastolic, typically are lower, or I should say systolic is lower. Diastolic doesn't change between sites. But the point that I wanted to make here is that a lot of people are being misdiagnosed with hypertension. So they could have, in theory, very high blood pressure out in the periphery, but lower pressure centrally. But yet they get diagnosed based on the peripheral pressure. And that unfortunately has led to a lot of people experiencing unwanted side effects of antihypertensive medications. And so one of the arguments for doing this arterial stiffness analysis is that it allows me to see what the central pressures are non-invasively to get a better overall indicator of what true pressures the heart's facing against. And it's done quite simply. So what we have to do from the tonometer on the neck, I'm going to get a pressure in the carotid, which is calibrated to the pressure in the brachial. And all devices use what we call a transfer function. It is a fancy algorithm that no one can look at. It's proprietary. But the manufacturers of these tonometers, what they'll do is they'll take the shape and the size of the pressure wave in the carotid and they'll calibrate it to the blood pressure in the brachial. And then they're able to, through the algorithm, figure out what central blood pressure is. And of course, this has to be validated. And so they do catheterization studies to validate their algorithm. But some are very effective at capturing central blood pressure this way. So just because you have high systolic blood pressure in the periphery does not necessarily mean that you have high systolic blood pressure in around the aorta. So, and we could get into the physiology why that is, but I just wanted to point that out.
Yeah. So if you have somebody that you're saying, oh, my doc just told me I have high blood pressure. And, would you say before somebody would go on blood pressure medication that it could be something that would be interesting to get a pulse wave velocity assessment to actually see how stiff the arteries are and sort of measure central hemodynamics
Mhm.
before going on a pharmacological intervention?
Yeah, great question. So first and foremost, I'm a PhD, not an MD, so I can never override what a
Of
physician
course, of
says.
course, of course.
But I would take it in context. If I have a diabetic who is also overweight, obese, and they have high peripheral blood pressure, chances are they're probably going to have central blood pressure issues as well. But yeah, if in those instances where you have this newly diagnosed hypertensive and there's no other signs or symptoms, perhaps a closer look at the central hemodynamic scores can give us a better indicator of whether or not this person truly does need pharmacological intervention. Um, Unfortunately, we're just not there yet. The the technique, the equipment, the infrastructure for doing all this is just not ready for it.
Okay. Yeah, so I know we're winding down here, but I definitely want to talk briefly about how we met and ultimately have started to pursue this line of research that's combining your passion and expertise for arterial stiffness and my thirst for understanding the ways in which we can safely apply blood flow restriction depending on the different types of features that a cuff could have. So for those that are listening, blood flow restriction, brief and foremost, is use of typically a cuff that's calibrated by some sort of technology that that when inflated to a percentage of your blood pressure for that particular cuff width, commonly called arterial or limb occlusion pressure, which is basically getting your blood pressure taken, but with a cuff of a variable size. And we exercise at a percentage of that. And a lot of research has come out in the last decade in particular that supports the efficacy of low intensity exercise with blood flow restriction. And they say low intensity exercise because blood flow restriction basically mimics the physiology or the muscular environment that would be present in high intensity strength training. Simplifying it, but that allows us to obtain the vast majority of the same benefits as if we were lifting heavy or we were doing a higher intensity cardiovascular exercise. So with that being said, my background is in BFR, specifically with a variety of different cuffs. So I teach with the BFR pros as part of my education wing. I teach with a variety of different BFR equipment. And I really am interested in understanding, is the marketing that's been given to the clinicians, is it really based in science? And does that have an impact on the way in which that individual or individuals respond to BFR exercise? And this is a brand new area of research. So new, in fact, that when Tim and I got connected via my colleague, Nick Licamelli, in what is this, 2020 or 2020, something like that. It was like a couple of years ago, that we basically, decided that we were going to merge my interest in understanding at that point autoregulation. So autoregulation is the use of cuff that can actually adjust to the phase of muscular contraction as you're going and doing an exercise. So for example, the cuff will attempt to maintain a similar pressure on the exercising limb as you're going into concentric or the muscle shortening phase, or the eccentric, the muscle lengthening phase. And that's been studied, or a lot of different devices have autoregulation, or some devices have it. And it's been studied very frequently in the Delphi personalized tourniquet device. But there's really, prior to us collaborating, there's really no evidence that autoregulation serves, any sort of effect other than being able to reduce the perceptual response relative to other cuffs that don't autoregulate, but also, which is another getting into the weeds, which is definitely not the topic of this podcast, that it was better able to maintain set interface pressure, which basically just means that when I plug in a value like 150, so if I'm applying 150 millimeters of mercury to your limb, that 150 millimeters of mercury is actually getting applied to the underlying limb. And as the pressure changes, it's able to adjust and maintain that pressure on the exercising limb. So besides that, there's really nothing out there that directly looked at the autoregulation feature when we first started discussing this project. We had a paper that was published before our paper that ended up that I also was involved in, that ended up reaching publication first, but ultimately that allowed us to combine our two expertise and knowledge to kind of figure this out. So want to just talk briefly about what we did in our first study in the lower body, and then talk about what we did in the upper body, and talk about the differences, since you were the one collecting data, in the responses, and what kind of we found, and what are our next steps in this collaboration.
Yeah. First, I just want to reiterate, Nick, he eats, sleeps, blood flow restrictive training. He's always thinking blood flow restrictive.
When did you hear about BFR first and foremost?
Probably a few months before I met Nick at Mark ACSM. And I'm looking for newer training techniques that have not assessed arterial stiffness. And so back in my mind, blood flow restricted training, gotta start analyzing this. This is new. This is something that's growing. We got to look into this. And so just got lucky enough to bump into Nick, and then he led me to you, and here we are. And so our first study, we looked at the effects of blood flow restriction training, autoregulation versus non-autoregulation. So non-autoregulated devices don't change diameter as the muscle is contracting. So that is thought to induce more pressure in the muscle and the vasculature during that contraction process. So we were looking at the effects of non-auto versus auto regulation on wall squats. And so we had about, I think, 25 participants where we put the devices around their thighs, and they went through 3 randomized treatment trials. One was auto-regulated, the other was non-auto-regulated, and the third was no BFR cup. And so they were training, they were doing 4 sets with or without these cuffs, using about 20% of the 1RM, and they were going to failure. So every time we would count how far they went for each set, and they would get a break in between. During the BFR sessions, the cuffs remained on and inflated. And then after the set, we also looked into some perception scores. So we wanted to know the RPE, RPD, and how likely
rate of perceived exertions, or how hard they're working, rating of perceived discomfort, how much uncomfortable feelings that were in the thigh, just for people that
correct. And then how likely would they do that same exercise again if they could? And what we found, interesting enough, we did see a significant drop in central pulse wave velocity in the autoregulated arm of the study. It dropped by about 0.5 meters per second. And when there's an increase in arterial stiffness of 1 or more meters per second, that is correlated with around a 10% increase in all-cause mortality related to cardiovascular disease. So, that's not nothing. Now, granted, this was just an acute response. So all we saw is just one bout of this training and reducing arterial stiffness a little bit with the autoregulated. The non-autoregulated and the BFR, there was no change. So with that, we wanted to move to the limbs, to the upper body limbs. And so we put together a similar study, this time putting the cuffs around the arms and doing bicep curls. 20% of the 1RM doing the curl, 4 sets to failure. And this time we found basically no changes between the stiffness scores. So whether we're looking at pulse wave velocity or another indice of arterial stiffness, which we call beta stiffness index, that involves some of the images from the carotid. We didn't see any differences between those groups. And speculating now, more research is needed. One of the reasons why I think we saw a change in central femoral pulse wave velocity in the leg, but not the arm, has to do with the anatomical location of the device. So the arms, the blood pressure cuffs are much closer to the heart, and that could have affected the return wave to the heart, speeding up the pulse, which could have impacted blood pressure and things like that. So where the cuff is further away from the heart, you might have more of a buffering effect. So where we're going next is we're going to be looking at whether or not there's a change in a single chamber cuff using Delphi Industry BFR cuffs versus a multi-chamber cuff, the B-Strong cuff. Multi-chamber cuffs have multiple pressure chambers in them, and they create a blood flow limitation during the venous return. Or you should probably
no, you're right. Yeah, I mean it's marketed as being a safer alternative for blood flow restriction, but this is, even though it's an acute study, this is going to give us an idea, which we didn't even really talk about in your 2 summaries, which I'll hit on. But staying with the topic of multi-chambered, it's specifically designed to not occlude, because inside of the cuff there's spaces and pockets in between the 2 air bladders, or in between the air bladders and between the 2 bladders that it would connect, that allow for expansion of the skin, and thus any sort of pressure that's applied is not necessarily, even though it's calculated in millimeters of mercury, it's not the same as a single chambered system. And so our interest now is in keeping on with this vein of arterial stiffness and separating the science from the marketing. Does this impact the arterial stiffness, but also the perceptual responses? So how comfortable the exercise is, and how hard they're working, which shouldn't really change because we're exercising them all to failure. And looking at the volume, which is the thing that was mirrored in both of our investigations, which basically showed that in the legs, there was no impact of autoregulation on allowing the exerciser to do more just because the cuff is autoregulated. And that's a really, really, really important finding. The arterial stiffness, that is very interesting as well in terms of it blunting, and that has the potential for people that have comorbidities. That, again, we did it on healthies, right? So we the next step in that investigation would be to do it on those with some sort of comorbidities, and then ultimately a longitudinal. But because the performance variables, so the volume and the volume load, which is just the amount of reps times the load, was not different between the BFR conditions, but both were significantly lower than the free flow, which mirrors the current body of evidence. Both BFR conditions accelerated repetitions to fatigue faster than the low intensity. What was really, really, really important about both of the results in our investigation, from my angle, right? Not the arterial stiffness angle, which is yours. My angle was, oh, okay, but the impact of autoregulation doesn't really have an impact on how many reps somebody can perform, whether it's autoregulated or not. Both of them are going to increase the amount of discomfort that's experienced by the exercise. And it was a moderate to high level of discomfort, which again, you would anticipate based on exercise to fatigue, which aligns with a lot of with the work that we did with our meta-analysis with one of my colleagues in Brazil. But I can't stress how important the volume issue is, because it doesn't impact the exercise prescription when you're using the Delphi personalized tourniquet device. Conversely, the study that I was involved in that was published prior, the first one in the field, was using another device, the smart cuffs, and the smart cuffs auto-regulation responsiveness is just not at the same level as the Delphi. So what they did in that study was we had people exercise in a 30, 15, 15, 15 rep scheme, and then a failure repetition scheme. And we had them do leg extensions. We did wall squats in ours due to equipment limitations. But they found that the auto-regulated cuffs actually were able to perform significantly more volume than the non-auto-regulated cuffs in the failure routine. And that perplexed me, but didn't really surprise me, just given the responsiveness of that auto-regulation feature. And that has a clinical importance, because if you're a researcher that you're now studying, or you're a clinician that's using BFR, using the smart cuffs versus using the Delphi, or using the Delphi versus the smart cuffs, you're going to have potentially different responses physiologically as well as on a performance basis. And the second part that Tim that we looked at, that Tim because he's an arterial stiffness guy and I'm the BFR guy, is ironically, we in either of our studies did not have a single adverse response to BFR exercise. Adverse responses could be anything from lightheadedness to worst case scenario rhabdomyolysis, which is excessive muscle damage, versus the first study that was out with the smart cuffs showed that auto-regulation actually had a near 3 times risk reduction in getting an adverse response, which the majority of our responses, I think 16 of them in the totality of the trial, only 16 adverse responses, of which 13 were dizziness or lightheadedness of various capacities, which can happen with BFR. We found none, which is also very surprising, because we did not have a light familiarization session. We went full blown, which is definitely not recommended in clinical practice, to have people exercise to volitional fatigue with BFR on the first session. So I guess, with Tim, Tim, what were the participants, kind of saying, and stuff that kind of is left off the pages of the research project regarding those interventions?
So yeah, there definitely was a big difference in perception or discomfort compared to no BFR. But comparing auto versus non-auto, I had a few participants that had a stronger discomfort response with the auto. It's generally, when you're performing these things, the discomfort is not as terrible as the rest period. So when you put the weights down and now you're resting, that seems to be the time when most discomfort is experienced. And so what I've noticed is a few of my participants being more vocal during the rest period with the cuffs pumped up, and this is during the auto-regulated. It could be because the cuffs are recalibrating, they're contracting harder during that time period. But needless to say, I had a few individuals that were only able to get a few extra reps after the first set. So they might have gotten 20, 30, 40 reps the first set, second set, third set, maybe 1 or 2. So That wasn't a common response, but I did see it probably 2 or 3 times.
So I guess is in our two research projects, and we're still going to continue along the vein of looking at autoregulation, and particularly considering that, we've done a multi-joint lower body exercise. We could do a single joint lower body exercise. We can do multiple exercises, which I think is really the next step, is just adding another exercise that's more indicative of clinical practice instead of just one. But we also can do a multi-joint upper body exercise as well. But where do you kind of see the role of autoregulation? And I must say, caveat, using the Delphi personalized tourniquet device, because that's the device that we're studying. Where do you see that as something that clinicians are weighing options of? Is autoregulation something that they should really consider?
Yeah, I think the impact will come from more of those longitudinal studies. Sure, we can show them that it's acutely safe, but they're going to be interested in the long-term impact. And so until those studies are produced, I think we're going to have a lot of physical therapists just sitting at the sideline waiting for those outcomes. So where I want to go next with our research is designing some of these longitudinal studies where we're having folks train 6-10 weeks with the BFR cuffs and just measuring arterial stiffness and perception scores along the way, just trying to characterize if there's any influence on the stiffening process. And we're also interested in not only just resistance training, but aerobic training as well. And so one of the things as a researcher, you try to find your niche, an area that's not explored, and you continue down this rabbit hole for as long as you can hold it. And so I think indeed we have a big rabbit hole that's going to keep us very busy for a long time trying to answer some of these questions so that clinicians can make the best decision possible for their patients.
Yeah, I mean, it's so funny just thinking about it, because really, prior to our study in the lower body, there really wasn't investigations utilizing central pulse wave velocity.
Yeah.
There was peripheral measures which do tell us some status of the arterial system, but in reality, our paper was really the first step in bringing, knowledge of arterial stiffness into the BFR space. And I think if, at least acutely, right, being scientists and understanding that we can't make gratuitous claims from acute data, but at the very least, we can say what about autoregulation, about BFR. What are the main takeaways from our work together thus far?
Thus far, autoregulation does not seem to hurt the stiffening process, and if applied to the legs, can actually help reduce some of that stiffening process. The other thing I would like to point out is the fact that when we looked at what was the likelihood of doing the exercise again, it was similar across all treatments, meaning that a lot of our folks enjoyed the BFR as much as they did the no BFR. They liked that discomfort, which is, confusing at first. But when you think about training and the nature of folks that are doing training, we're all used to muscle pain, and pain equals gains is usually is the mantra. And so knowing that you're partaking in an activity that is going to eventually lead to more physiological adaptation, it makes you happy. And so, and we calibrate ourselves to that pain because we know that pain is associated with some type of muscle damage, impairment that will eventually lead to more adaptations down the road. So that I found encouraging is that a lot of my participants love doing the BFR stuff. And they were constantly asking me, where can I buy this? Where do I get this? I'm like, well, Delphi is not on the market. You need a physician prescription for it. But there are other devices out there on the market. But of course, buyer beware. Some of the claims and some of the weaknesses of those devices. Yeah, that's all I got for that one.
No, I think that's very appropriate. I think for me, as you kind of tacked on the enjoyment, but also the arterial stiffness responses, for me, again, it goes back to, if you're a clinician and you're utilizing the Delphi personalized tourniquet device, you can be assured that you're not going to, it's not going to be any different than if you didn't have autoregulation, meaning that the Delphi, which you can't do anyways, because we had it specially manufactured a setting, but that if it didn't have autoregulation, it's not like you're going to be able to do more or less work for your clients. And I think that's important when we talk about prescription of BFR. I think that we've done a very stressful protocol on purpose. It is a healthy population, right? That's why we had them exercise to fatigue. That gave us the best chance to induce an arterial stiffening response. And this should be reassuring that when we think about one of the safety concerns about blood flow restriction, and again, I preface this as the fact that these are healthy participants, but even in that, there is evidence to suggest in compromised populations, much like normal resistance exercise has been now more and more promoted as a beneficial therapeutic approach than other, sitting there and doing nothing, right? Or even taking pharmacologicals in some examples, that BFR is likely safe on the heart. I think that is something that has been brought up and is mentioned not super frequently, but frequently enough where our assessments should give credence to the idea that it doesn't create an unnatural physiologic stress to the heart. And in fact, based on the body region, might even be something that is somewhat protective. Although again, who knows what happens in a longitudinal design. And I still am shocked that in 50 plus participants, in no one had an adverse response of any kind when exercising to volitional fatigue. I think that is a very more unique response, in that I would anticipate at least one of some way, shape, or form, like reduction in pressure, right? We also used, to be fair, a lighter relative pressure of 60% of the supine limb occlusion or arterial occlusion pressure. And we did that just because that's kind of the minimum therapeutic value in the legs, at least. And we did that in the arms as well, which is a little bit more than what is recommended, which should also give you comfort if you're a clinician, because now you're like, okay, I'm having people doing upper body exercise and there's no difference between autoregulated, non-autoregulated, or low load exercise. And it really didn't create a negative stimulus. And thus, should give you a little bit more comfort. And those kind of, for me, putting my physical therapy hat on is kind of the takeaways from our two investigations thus far. Anything to add?
No, you're right in line. We looked at rate, pressure, product, the workload of the heart. It's a simple equation: heart rate lifetime systolic blood pressure. We didn't see any differences between groups. So yeah, with respect to the heart, in an acute trial, that the BFR does not seem to have any negative consequences on the cardiovascular network. And as you said, should give some relief to clinicians who have patients suffering from cardiovascular disease. But again, those studies are still needed to ensure
that would be a great, that would be
an ideal study to do.
Great, but unfortunately, limitations in a lot of things. Maybe one day. All right. Well, let's wrap up. So if you have one or two things that listeners should walk away from regarding arterial stiffness, what should they be?
One of the big recommendations, take-home messages from the classes that I teach, exercise seems to be one of the best treatment options for limiting the development of arterial stiffness, because we're all going to have stiff arteries as we age. The longer you live, the more likely you're going to be exposed to inflammatory agents, high glucose, high pressure. So stiffening is going to happen, but a lifetime of exercise can rescue from a fate of stiffer arteries. So I know it's not selling aesthetics for a lot of folks right now that want to exercise to look better, but it is indeed medicine. It's a very, very potent treatment for blunting the effect of arterial stiffness later in life. But then again, if we look at pharmacological interventions, they can also be somewhat supportive. One of the issues with pharmacological interventions, they might only attack it at one front. So you have three different fronts that are causing it. You take high blood pressure medicine, so you knock out one of the fronts, but there's still two other you have to contend with. And so a lot of these folks who are on polypharmacy, they're taking multiple medications. A lot of this can be substituted with exercise. Now, push the corner. What type of exercise should someone be doing? We're still recommending both a aerobic and resistance training regimen. We do not favor one over the other. We want both, because both stress the body in different ways, eliciting different physiological adaptations. So in a nutshell, follow the ACSM guidelines and you'll see stiffness profiles improve. I think that's my big take-home message from this right now. Whether or not
I think we hit on all of our blood flow restriction takeaways, so no need to rehash those.
You can edit this. It's like, crap, did I say that?
So I guess, where can people find you if they want to reach out? Is there anything that you want to give end of podcast shout out to? Now is your time before we wrap up.
Well, yeah, I love questions, and so if you ever want to contact me, again, I'm at Salisbury University in the exercise science department. My email is tjwerner, that's TJWERNER at salisbury.edu. And I just want to give a warm thank you to Delphi Industries for allowing us to continue with this research as we keep going down this rabbit hole. Cool. And Nick, of course, I got to thank Nick. He comes up with all the great ideas.
I'm just fortunate in this collaboration to be able to merge our two interests into fruitful research collaborations, and there is so many that we can pursue. So I'm just really excited for the future, and I just wanted to say thank you so much for hopping on the podcast. And this has been
a lot of fun.
Yeah. And this has been the BFR Better for Results podcast with me, Nick Rolnick, the human performance mechanic, signing off. Have a great rest of your day. And that was today's episode of the BFR Better for Results podcast. If you enjoyed the episode, I would love if you subscribe to the podcast on whatever platform you're watching or listening on. I really appreciate the support.